I think a very important communication here at EHA in Amsterdam in June of 2019 was a report from my colleagues at Princess Margaret Hospital that looked at their quite extensive experience with JAK kinase inhibitors in myelofibrosis patients now that we've had access to them for more than 5 years, and to see how people do on this long term. So this actually is for one single center, a quite large cohort of 100 patients. And interestingly, the drugs that they were administered include both ruxolitinib as well as momelotinib on trial. So it's a good cross-section of JAK kinase inhibitors, not specific to one particular drug. And as I said, most patients had had it for 5 years. And interestingly, in keeping with what has been reported in the long-term follow-ups with the COMFORT trial, a fair number of patients need to come off it. In their particular cohort, less than 20% of patients were still on it after 5 years. And the communication did a really good job of pointing out the fact that the reason for discontinuation is something that needs to be looked at quite closely. And as a matter of fact, there's a Canadian effort now to make this quite explicit in terms of why people need to come off it, either intolerance or failure. And failure can be due to many different aspects of their disease being progressive. In this particular communication, they talked about the unfortunate small number of patients who went on to have blast crisis, those that had progressive splenomegaly after they had had initial response, and those who developed cytopenias. The interesting analysis that they were able to perform indicated that, as you might expect, the blastic transformation had a very poor survival of about 3 months. The spleen size enlargement was, if you want, of the three, the best, but that still was relatively grim with a survival of less than 3 years. And the cytopenias was in between. This is a very nice parallel to another type of analysis that was also done in polycythemia vera, where the particular type of either resistance or intolerance to hydroxyurea actually made a difference. For example, cytopenias, but not non-hematological intolerance of hydroxyurea and polycythemia had a survival disadvantage. This mirrors that experience and quantifies it. The other thing that they did was to look at extensive gene analysis of 54 genes, including the high-risk genes, and they indicated when they were used to calculate the MIP70 or the MIP70 plus score, both scores, when they were high, predicted progression, as you might expect, because that's what they were designed to predict, but also predicted survival in this population of real-world patients. So I think it underlies the magnitude of the unmet medical need. It shows us how to analyze it, and we look forward to having a very explicit tool as to how to characterize these patients. And it shows us that genetic analysis may help us further identify people up front who we might anticipate might not do as well.